Good day, ladies and gentlemen. My colleagues and I are a group of physiotherapy students from Beirut Arab University. We are pleased to be presenting our project discussing the evaluation of the clinical diagnostic accuracy and reliability of Lebanese doctors of physical therapy, known as DPTs, exclusively in patients with subacute shoulder pain. It is widely agreed on that the orthopedic doctors, OPs, are the most frequently consulted practitioners for musculoskeletal cases, as they are considered a benchmark reference. The term diagnostic accuracy is the amount of agreement between the results of one test and the gold standard reference, whereas the term diagnostic reliability is the amount of agreement between the results of one test being conducted multiple times under identical conditions. These two terms are essential to ensure that the clinical diagnosis is what suits the patient's safety and health, therefore leading to a suitable treatment plan. This study enrolls an OP specialized in shoulder joint disorders, providing a benchmark diagnosis for every case, then comparing each diagnosis with its collateral one, provided by the DPTs and OPs. Similar studies were previously conducted, concluding that there is no significant difference between the diagnostic accuracy of the OPs and that of the DPTs. Another study concerning the cost-effectiveness of physical therapy treatment showed that it is less expensive and equally accurate alone when compared with physical therapy treatment combined with medical treatment. From this point forward, this study aims to improve the quality of healthcare by studying the diagnostic accuracy and reliability of the DPTs in Lebanon exclusively in musculoskeletal shoulder conditions. However, we predict that there won't be any difference discovered between the compared factions.
Diagnostic accuracy, as already mentioned, refers to a test's capacity to distinguish between disease and health. Measurements such as sensitivity, specificity, and ratios can all be used to quantify diagnostic accuracy. Sensitivity refers to a test's ability to label an individual with disease as positive, whereas the specificity of a test is its ability to label an individual who does not have a disease as negative. Regarding diagnostic reliability, inter-rater reliability refers to the compatibility between two or more raters performing the same test under identical conditions, whereas test-retest refers to the compatibility between results of the same test repeated under identical conditions. Cognitive factors in clinician decision-making are contributory causes of more than half of diagnostic errors, while system errors such as miscommunication or follow-up of laboratory test result are less frequent. Regarding objectivity, it is one of the most essential elements in scientific research, meaning that all scientific claims are not to be influenced by any bias. In order for a diagnosis to be considered reliable, the same results must be achieved multiple times under the same conditions, supported by studies showing that a minimum number of 3 repeated diagnoses is required to be able to evaluate reliability. Furthermore, a study shows that having a gold standard as a reference ensures objectivity and accuracy. Moving forward to the difference between medical and physical therapy diagnoses, we must mention a medical diagnosis is the process of identifying the nature of a disease according to the patient's signs and symptoms. The procedure of a medical diagnosis includes history taking, carrying out a physical examination, further diagnostic testing such as blood tests and imaging, then finally deducting a suitable diagnosis. However, a physical therapy diagnosis is the clinical judgment reached by the therapist after collecting data, evaluating it, generating and testing a hypothesis. Data collection includes the patient's medical and family history, as well as specific physical tests and measures, such as charts and assessment scales. Literature must mention that there are relevant factors contributing to diagnostic errors such as human error, availability of diagnostic tests, affordability, training of healthcare providers, and follow-up.
A double-blinded, observational, analytical, cross-sectional design was utilized in this study. None of the participants knew the main purpose of this study, and they all agreed not to inquire about anything that may interfere with the objective diagnostic procedure. A researcher from our group was present during each assessment session to ensure that the blinding criteria was not interfered with. In addition to that, all participants signed a consent form regarding these details. 5 OPs and 5 DPTs were recruited. A total of 30 patients aging 20 to 26 were eligible to participate in this study, but only 5 were recruited. 1 patient dropped out due to time conflict and was consequently replaced by another participant. Finally, another participant was added, totaling 6 patients. This number of recruits was based on a study in which a ratio of 3.07 cases per specialist was used to evaluate diagnostic accuracy and reliability. Concerning the OPs and the DPTs who were included are Lebanese, residing in Beirut and registered in Lebanon. The included patients were chosen suffering from subacute, non-traumatic shoulder pain and between the ages of 20 to 50. On the other hand, patients who have received any type of treatment or have any chronic systematic or neurological diseases were excluded. Moving along to the recruitment of OPs and DPTs. In-person meetings were held with those eligible to participate, after having contacted their hospitals and clinics. As for the participants, a questionnaire regarding our inclusion criteria was made and shared on social media platforms. Discussing the process. The study started by assuming that the OP specialized in shoulder joint conditions is accurate and reliable, and whose results were used as a benchmark reference, gold standard, for evaluating all other diagnoses provided by the OPs and the DPTs. All of the participants visited 5 OPs and 5 DPTs, but 2 only saw 4x4 due to time limitations. All orthopedic doctors were asked to clinically assess the patients without requiring medical imaging results or blood tests. Finally, each specialist was asked to write down a clear diagnosis of each case, as well as the steps of the diagnostic process, which are relatively the main outcome measures of this study.
A chi-square test of independence showed that there was no significant difference between the diagnostic accuracy of OPs scoring 44% and DPTs scoring 27% as shown in the figure on the screen. In addition to the bar graph showing the interreliability between the OPs, DPTs, and the reference, this graph shows the frequency of agreement with the reference, where the highest agreement was 4, scored by 2 OPs and 1 DPT. Moreover, the bar graph in figure 3 is showing the frequency of diagnostic agreement of each condition of the assessed shoulder joints. Consequently, we must mention that both reliability percentages are not considered reliable enough, as literature recommends a minimum of 75%. We observed that the shoulder conditions which had the highest agreement by the OPs were labral tear and acromioclavicular joint dislocation, 2 conditions frequently referred to and treated by orthopedics, while the highest agreement of DPT was observed in cases of shoulder impingement. As for the diagnostic accuracy, the chi-square test of independence confirmed that the difference between the accuracy of the OPs and that of the DPTs is negligible, and that both are equally inaccurate in cases of shoulder conditions. In summary, the results of both groups of specialists show that neither DPTs nor OPs in Lebanon can be considered either accurate or reliable when individually diagnosing patients with subacute musculoskeletal shoulder joint conditions. Yet, this is not an unlikely result, because an American nationwide study showed that the enrolled physicians were only 6% accurate in diagnosing difficult conditions, which is lower than the scores obtained in our current research. Based on this data, an important recommendation would be to encourage collaboration between specialists to achieve higher diagnostic accuracy and reliability. This could be accomplished by exchanging information, referrals, or consultations. A study comparing the accuracy of diagnoses reached by a group to that reached individually showed that the diagnostic accuracy increased with the grouping rather than individual diagnostic efforts. All in all, interprofessional communication and collaboration is important for patients' care safety, as it increases diagnostic accuracy and reliability, especially in conditions which are considered complex, such as the musculoskeletal conditions of the shoulder joint. Lastly, our sincere appreciation to Abu Dhabi University and Beirut Arab University for the opportunity to participate in this competition. In addition to our group members Shatin Bou, Hassan Tanir, and Wasim Saifuddin, and our mentors Dr. Faiz Otabashi and Mr. Mustafa Zibdawi for their help and guidance. Thank you.